Okay, I think we're all bored, so we'll just get going and get the session. We had a great session earlier on coronary disease and looking forward to this one. My co-chair is a good friend of mine from Japan, Dr. Yamaguchi. The first presenter today is Aubrey Almeida, good buddy and president of our society in Australia. He's going to talk to us on modern MR and CABG, the fix or not, to fix or not. Thank you, Aubrey.
Thank you. Thanks, Trevor, and thank you to the organising committee for asking me to speak. This is an additional talk to the 3 I was given, so it's been put together on the hop, but hopefully it will cover the area quite well. So my remit today was to talk about what to do about a patient with moderate mitral regurgitation who's having coronary artery bypass surgery. And just so the audience is aware, what we're really talking about is not patients who've got moderate MR with degenerative disease or rheumatic disease, but really what to do about those patients who have ischemic mitral regurgitation in association with their coronary artery disease. And we should understand that the mechanism of this is due to changes in the ventricle with local LV remodeling, with papillary muscle displacement, abnormal mitral annular contraction, and dilatation of the left ventricle. And the combination of those three things is what gives us this type of functional mitral regurgitation. And the mechanism of it is in association with changes in the annulus, changes in the ventricle, and changes in the vector forces on the mitral valve. We get this increased tenting under the valve. And as you can see from this diagram, that tenting is worse on the secondary chords to the anterior leaflet. So what we're seeing is a regurgitation jet that can be central. Quite often it's also due to a relative override and therefore get an eccentric jet also. So that's the mechanism of the mitral regurgitation we're talking about. And I think why is this important? Because in fact it's a relatively common phenomenon. And somewhere between 10 and 20% of patients with coronary artery disease will have some degree of mitral regurgitation. And if we then look at those patients who have at least moderate mitral regurgitation, it comes in somewhere between 5 and 7%, depending on the studies that you read. And it's important also because it has a significant impact on survival, and I know Tony's going to be talking a little bit about this in terms of acute myocardial infarct. But certainly patients who have infarcts who have mitral regurgitation do worse, and certainly the worse your mitral regurgitation, the worse your outcome in the long term. So if we have a look at this graph here, if you have no mitral regurgitation, that's the upper curve, that's your long-term survival. If you have relatively mild mitral regurgitation by ERO criteria, it has an impact on your survival. And once you get to an ERO of 20, then that has a significant impact. And those things continue over time. So bottom line is, the worse your mitral regurgitation is in association with coronary disease, the worse you do. And that's been supported in a number of papers. If we have a look at this, if you have moderate ischemic mitral regurgitation and you undergo CABG, your survival in the long term is worse than if you have none or mild mitral regurgitation. So basically what we can say from these studies is that moderate mitral regurgitation is an independent predictor of mortality. That doesn't mean necessarily that correcting the mitral regurgitation will resolve that mortality difference, but that's something to look at in our consideration. So as always, the studies that we have looking at these are quite limited. By and large, they're small patient populations, and unfortunately we're a bit reliant on looking at meta-analyses. So if you have a look at this meta-analysis of 9 studies, the patients who had coronary artery bypass alone, there were about 1,500. Those that had coronary bypass and mitral valve surgery, around 1,000. If you did the mitral valve operation, the mitral valve repair, you had a lower incidence of mitral regurgitation, so it did improve the MR. But in this meta-analysis, there was no difference in survival and no difference in the symptomatic status of the patients. So just to give you a halftime summary, basically what that tells us is that ischemic mitral regurgitation post-MR increases mortality. The worse your MR, the worse the outcome, but not a lot of evidence that operating on moderate MR changes the patient's prognosis. I guess the next question we could ask ourselves, saying there's a relative lack of evidence, is why should we correct 2-on-4 MR anyway? And I guess logically we'd say, well, we all know that if you reduce your afterload, that you reduce the radius of the left ventricle. And if you reduce the radius of the left ventricle, you reduce your stress forces, you reduce the work the ventricle has to do, you reduce your oxygen consumption, and the ventricle works better. So purely as a treatment for afterload, then treating the MR is a useful thing to do. We also know that if you treat people's MR, that your ejection fraction improves over time. We know that from both ischemic and degenerative mitral regurgitation. And the other thing that we know is that over time, if you leave patients with MR and that volume load, that they'll get left atrial stretch, which increases atrial fibrillation, increases annular dilatation, and left ventricular stretch, which also increases the likelihood of MR. So bottom line is MR begets MR. And really there's no surprise there, and that's all very logical. On the other hand, we've got to balance that against the risk of doing the mitral valve operation. We know that the surgery is a bit more complicated. You're going to have a longer cross-clamp time, a longer bypass time. Some of these functional mitral regurgitations aren't all that easy to treat with a simple annuloplasty ring, and they may require either complex mitral valve operations with papillary muscle changes, etc., or you might have to replace the mitral valve. And no matter what anyone tells you, there's no such thing as a foolproof, guaranteed mitral valve replacement. You can always make mistakes and they can always cause problems, and especially in a patient who's marginal anyway, that may be a problem. You could also say, well, in certain populations, the mitral regurgitation will get better anyway. So why am I doing this if by revascularizing the patient, things will get better? And as I said from previous studies, there's no clear evidence that surgery will prolong survival. And then when we add this to some of the later papers that we have seen on ischemic mitral regurgitation, the long-term results of mitral valve repair in this population are not ideal. There are a few papers that we can look at that perhaps would give us a little bit of guidance as to how we can select patients a little bit better. This paper is quite interesting. Basically what they looked at is that in patients with grade 3, so moderately severe mitral regurgitation, perhaps not the grade 2 we're talking about in this talk, who underwent surgery. They had 29 patients, they had bypass and annuloplasty ring, and they did MRI scans on these people. And what they found was that 90% of the patients after ring annuloplasty alone had no mitral regurgitation. But at 6 months, 34% had recurrent moderate mitral regurgitation. But if you had a look at those patients, if you had the presence of extra scar, especially in the region of the posterior papillary muscle group, you were much more likely to get recurrent mitral regurgitation. Whereas if you didn't have much scarring, you actually tended to do quite a lot better, and your residual mitral regurgitation was less. There's this other paper that, again, is quite interesting, and basically these patients were randomized to having CABG alone versus CABG and annuloplasty. They looked at a whole lot of factors. Really not a huge difference in 5-year survival in this patient population, about 5% difference. What they found, though, that was interesting was that in about 40% of people, just doing the CABG improved the mitral regurgitation. So, in fact, there is a subset of population where, in fact, treating the ischemia will help resolve the mitral regurgitation. So, again, maybe some interesting information. So the paper basically made the point that mitral valve repair does improve the cardiac function, but some patients will get better without the repair. There's another paper looking at 135 patients with moderate mitral regurgitation and coronary disease. And what they did was they did isolated CABG on the patients, not treating the mitral regurgitation. Interestingly, for this population, they had 14 patients who died in the 12-month follow-up period. So not a low-risk population, or perhaps not good surgery. I'm not going to say that. And what they looked at was what happened to those patients and their mitral regurgitation. So 57 of those patients had improvement in their mitral regurgitation with no treatment of their mitral valve disease, whereas 67 of that population failed to improve. And the big thing that made the difference in these patients was the degree of viability. So essentially, the more segments of viability you have on preoperative MRI scanning improves the chance of recovery of ventricular function. And not having dysynchrony in the movement of the papillary muscles also made a significant difference. So not a lot of evidence out there, but certainly some baseline evidence that says, well, if you have more scarring, especially in the posterior wall, especially in the posterior papillary muscle group, the likelihood of getting recovery without annuloplasty or without treatment of the mitral valve pathology is less. So in the last few minutes, what do I do? Well, I guess it depends. Depends on a few things. Depends on the valve, and it depends on the patient. So we need to make a clinical decision in each of those circumstances as to what to do. One of the really important things, though, is that we need to be clear that this patient actually has moderate mitral regurgitation and that, in fact, on the table, we're not making a mistake in assessing the degree of MR. And so one of the really important things with ischemic mitral regurgitation is it's dependent on afterload and it's dependent on preload. And when you go to the operating room, you almost always underestimate it unless you take maneuvers to make that. So in my way of thinking, if you have an echo beforehand which says the patient has moderate or moderately severe mitral regurgitation on a transthoracic study, you need to believe that transthoracic study, even if on the table the MR doesn't look too bad. But if I'm still not sure, what I do is I'll push up the blood pressure, and sometimes that'll make the MR look more apparent than it was when the patient's hypotensive. But in particular situations where I do think it's an important decision, what I'll do is I will cannulate the patient, and just before going on bypass, give them extra volume through the aortic cannula and give them an increased preload as well as an increased afterload to assess the mitral valve. The other things I look at is it going to be an easy repair? How big's the left atrium? How much annular dilatation do I have? How much restriction is there of the leaflet? And clearly, if someone has calcification or marked restriction or complex pathology, then you need to think carefully about, do I really need to do something here? Equally with the patient, low-risk patients, first operation, simple operations, younger patients, definitely people that you would consider doing something on because you've got a lot more to gain. On the other hand, in those high-risk patients where you've already got a long operating time, you're doing a redo, etc., those are the patients where you might not consider it. In the last couple of minutes, I'd like to show you this case and see what you think. So this is a 71-year-old man who presented with shortness of breath on exertion, had a MI 28 years prior to this presentation and another MI 22 years prior to that presentation. So long history of ischemic heart disease. Typical patients we see, hypertensive, diabetic, smoker and obese, so the whole sort of gamut of risk factors. And his angio showed a blocked LAD, blocked right, an 80% circ, and the preoperative transthoracic showed grade 3 on 4 MR and an EF of 35%. The intraoperative echo was moderate. They said moderate MR, grade 2 on 4, and moderate LV dysfunction. And this is what the pictures look like. Doesn't look horrendous. You can see a little bit of tenting of that anterior leaflet, that seagull sign I call it, where you see the secondary chords, those strut chords pulling down. This is what the colour looks like. Not particularly terrible, but when you load the patient a bit more and increase their blood pressure, in fact, the MR was truly moderate. A little bit difficult to see, let me just go back. When you pause it there, you can see, in fact, it actually is a significant, very wide jet of mitral regurgitation. So let's go on. So we did a CAGs and put an annuloplasty ring, right size for the size of the anterior leaflet, not a downsize annuloplasty. You can see we've got a fair bit more tenting of it. You can also see that there's no MR, but we've also given the patient a degree of mitral stenosis. You can see that pesodome. So, you know, you're sometimes trading one pathology for another perhaps. And one of the problems with annuloplasty ring alone, and this I think is an interesting discussion to have with people who do a lot of ischemic mitral regurgitation repairs, often with an annuloplasty ring alone, you will make the tethering worse. So what we're really relying on in this sort of patient though, is that while the annuloplasty ring will improve the MR in the short term, what we're relying on is the LV recovering so that in fact that tethering will go away to get a good long-term result. I don't think people may have been paying attention, but that patient I operated on 10 years ago. So those images I showed you were from 2009. And now the patient's 81 years old. He's in NYHA class 1, goes hiking a couple of times a week, lives in Tasmania. His echo now shows no MR. Mean grade is 4 across the mitral valve, which is reasonably acceptable, and his EF's gone up from 35% to 55%. So one I got right, perhaps. So in summary, moderate MR is associated with worse prognosis. The decision to operate on the mitral valve and what sort of management depends on an accurate assessment of the mitral regurgitation and the mitral valve pathology, some sort of prediction of what you think about the chance of ventricular remodeling with scarring, and obviously patient factors are critical because not every patient's exactly the same. Thank you.
Thank you very much. Any questions from the floor?
Perfect. Stunned silence.
May I start one question?
Yes.
In your practice, the size of the ventricle with size of the left ventricle, which correlate to the mechanism of the moderate MR in today's talk, how do you assess the small ventricle, the big ventricle, with the same amount of moderate MR? How do you feel about that?
Again, I did, you know, in the sake of time, I didn't want to go into all the details. I mean, there's a lot of work done by a number of people looking at that. I must say, I still think that it's quite a diverse population, and even what we call ischemic mitral regurgitation is not always the same beast. There are some people who have a more global cardiomyopathy and a much more spherical left ventricle, and those patients I don't think do very well because you need to do something to centralize the papillary muscles. And I think the patients with a very dilated ventricle, an annuloplasty really, all that will do is increase the tenting and then give you much more stress forces on the mitral valve. And I think those are the patients where you really need to do something if we're repairing the valve to centralize the papillary muscles, whichever technique you think is the best. That's a different argument to have. And I think you have to be careful because even in moderate mitral regurgitation, that can still be the case. And I think not all moderate mitral regurgitation will respond well to an annuloplasty ring. You know, just the severity alone of the MR is not necessarily an indicator of which form of mitral valve therapy is the best one.
Right. I mean, you have been repairing mitral valve after MI, and that a technique we learned from Calafiore long back in year 2000. When we hardly put an annuloplastic ring, we used to use a 4-centimeter Teflon felt from commissure to commissure and push the posterior commissure little forward. And that really, helped getting rid of this MR for long since. But recently, I think from 2016, we are putting again the leaflet. You have any experience for this for, in the poor countries or less affluent patients in a government setup or a setup where, does it help, or you have any comment on it?
I haven't used that technique, but I have used the various ischemic mitral regurgitation rings of all descriptions. And we have the ones where the etiologics, where it's got a narrower AP diameter in the posterior, on the posterior medial commissure side. I must say I've gone away from that. The type of annuloplasty ring I use in ischemic mitral regurgitation is different from what I use in degenerative mitral regurgitation. I will use a complete ring always in ischemic, and I tend to use one with a narrow AP diameter. Again, not every patient fits that nice picture where you say, well, it's only in the posterior medial papillary muscle group that pulls away, and that you get tenting only in that area and it's fine on the other side. I think it's tempting for us as surgeons to want one answer to every problem, but I don't think that exists. And I think what is important is assessing all of that very carefully. And then, a lot like in a degenerative mitral valve repair, imagine what the repair will look like when you've finished. And
assessing is also important. I mean, is it difficult sometimes? Yeah. Putting TE, and then in preoperatively transthoracic echo shows MR of grade 3 or a little more. But lying down the patient in the OT, they get down, as you said, that's correct.
No, for sure. And I think, look, the transthoracic, I would always believe the transthoracic for severity, but not for mechanism. Use the intraoperative TOE for mechanism. But if you happen to accidentally discover it in a patient that hasn't had an echo before, bumping up the blood pressure to at least 130, 140, but try this, put the cannula in and give them 400 mils, 500 mils of volume, and see what happens to the MR. And you'll be surprised how often it's actually
hidden,
a lot worse than you think.
Thank you.
And it's quite safe, because then you just run on bypass and you take the volume off.
Thank you very much. I want to introduce the second speaker. Is Tony Fornery. The title is Severe Mitral Regurgitation Post-Acute Myocardial Infarction, When and What to Do. Please start, Tony.
Thanks, Satoshi. Appreciate it. So when I was giving this talk, I wasn't sure if they meant immediately post-AMI, like a day ago, a month post-AMI, 3 months, 3 years post-AMI. So I kind of took a shotgun approach. What am I not pressing on correctly? There we go. So what I thought I'd do is I added the term why. So what to do, when to do it, and why to do it, because why is important. So I'm going to start by looking at the incidence. What's the incidence of MR with MI? Aubrey gave you a little bit. What to do? Should we repair? Should we replace? There are some instances. There is an instance where we shouldn't even touch the patient. And this is for severe MR. When, what to do in acute management, when do we do what the different things we do, and then when do we operate on the patient? And then why? We'll look at some short and intermediate term results in a couple of papers, and we'll look at the long-term results from Portland that go back over about 40 years. So if we look at the incidence of acute AMI, and this dovetails with what Aubrey said, if you look at acute MI, there's about 17% of patients who come with an MI that have mitral regurgitation. And moderate to severe is about 3% of those. The interesting thing is if you look at the mortality in that patient population, the operative or the peri-acute MI mortality, it's about a quarter, 24%. And the 1-year mortality is upwards of 50% in some studies. Now, if you come in with cardiogenic shock and acute MI, you're at 40% of those patients will have moderate to severe or severe MR, and the 1-year mortality, as you all know, is about 70%. In terms of etiology and in terms of anatomy, we're pretty much talking about the posterior medial papillary muscle dysfunction. And the reason it's posterior medial papillary muscle dysfunction, whether it's rupture or it's partial rupture or it's long-term ischemic dysfunction, is because that's supplied by a single arterial blood supply, the PDA. But the anteromedial artery has LAD, has the circumflex territory, it basically has a dual supply, and it's much less at risk for ischemic disease of the anteromedial papillary muscle. If you get a papillary muscle rupture, it usually happens somewhere between 2 and 7 days, and so there's always just like VSD, which I think, Aubrey, someone's going to talk about after this, 2 to 7 days after, but about 50% of patients have a delayed admission, delayed diagnosis of their MI. So they come in with acute MI, but it's already a completed MI. So that further complicates the whole pathway. When I refer to MR in this talk, we're going to call severe MR. So what? What do we do? And I think the three choices are probably the most common one for true ischemic MR is coronary bypass plus mitral valve replacement. There is a role for coronary bypass plus mitral valve repair. As I told you, there's a very rare circumstance, which I've seen 3 times in my career, when you should not operate on the patient at all, and they will survive. So basically, if the patient comes in and does not have troponin elevation, that means they had this is old ischemic disease. And so they're well status post MI, and they can have an elective cath, and that's what they're going to do. But if they come in with an elevated troponin, they fall into one of 3 categories. They either have a Q wave MI, they have a ST elevation MI, or they have a non-STEMI. Okay, so this is a patient with acute MI. So what do we do with these patients? If the patient's had a Q wave MI in our institution, they come in with Q waves and chest pain, or they come with a STEMI, they're going to go right to the cath lab. They're going to get emergently cath. And in the cath lab, if a patient comes with a non-ST elevation myocardial infarction and they're unstable, they're having runs of ET or they're hemodynamically unstable, they're also going to go right to the cath lab. So they get an emergency catheterization, and we discover what this whole session is about: coronary disease plus mitral regurgitation. Now, if this is an unstable patient, obviously we're going to ask the cardiologist. We're not going to rush them off to the OR. We don't want to do that. So we're going to ask them to stabilize the patient and put a balloon pump in, and hopefully that stabilizes the patient. So now we either have a patient with one of these 3 diagnoses who has a balloon pump in place or not, and if they don't have a balloon pump in place, that means they're stable. And there is a scenario where the patient comes in, has an MI, and gets cathed, and they have severe MR. And remember, anything we're talking about in this talk is severe mitral regurgitation. And they have no coronary disease. And if they're unstable, and the cardiologist puts a balloon pump in, what happens? They get worse mitral regurgitation. So as I said, it gets impressive on your career when you see this, and I've seen it 3 times. And I've been challenged. I've been told I have to operate on this patient, and I look at it, and here's what we see in the cath film. Does everybody know what that is? So this is the Takotsubo Cardiomyopathy. And it happens due to either embolus down the LAD, or it happens due to spasm of the LAD, or it happens just due to stress and spasm of the coronary arteries. What you see is a hyperdynamic basilar contraction, and you see basically akinesis of the apex. And if you operate on that patient, you could probably do a mitral repair or replacement, and some patients have had that, but you don't have to. If you treat this patient medically, and so the answer to this question is Takotsubo, is you treat this patient medically, get them through this period of time, they will gradually recover over the next 3 to 5 days and have no mitral regurgitation. And the first time this happened to me, and I told the cardiologist I wasn't going to operate, he told the family that it was malpractice, and within 3 days, the family was thanking me that the patient didn't have an incision on her chest because her MR completely went away. And once you see it, you'll never forget it. So that is the one situation. Back to the ones that we want to operate on. If a patient comes in as stable and they have like a non-ST elevation myocardial infarction, they're going to get an urgent cath sometime during that hospitalization. So whether they get an elective catheterization or urgent cardiac catheterization, we're all going to end up, because of this talk, we're ending up with coronary disease and severe MR. So what's the next step? What's the next thing we do? Next thing we do is obviously an echocardiogram, as Aubrey said, to define what's the etiology of the MR. And the etiology of the MR is going to put us into one of those other two categories because we're not going to medically treat these people. They're either going to have, you're going to find that they have a partial or a full rupture of the papillary muscle, in which case I believe they need mitral valve replacement, or they're going to have tethered cords. And it's very difficult, as we'll see when we look at the long-term studies and long-term results, to look at tethering of the mitral valve, repair versus replacement, and we'll see why I'm recommending replacement. Now, there are patients who come in who happen to have an MI, but they've had old, long-standing mitral regurgitation. It has nothing to do with ischemia. So patients will come in with a torn cord or a myxomatous valve, can have a flail leaflet, which is why it's important to actually look at what the etiology is. Because in those cases, you can repair the valve, do the coronary bypass, and you basically are doing a degenerative MR plus coronary disease. Not all mitral regurgitation, not all severe mitral regurgitation with coronary disease is ischemic mitral regurgitation. So we're defining whether this is ischemic or not. And the last piece that you can see, which kind of goes both ways, if you see a dilated annulus, and a dilated annulus kind of goes both ways. It can be functional or it can be degenerative. And typically what I say, if the EF's greater than 40%, the EF's less than 40%, I tend to believe that's more functional. It causes long-term dilatation either from AFib or a bad ventricle, and I'll tend to replace the valve rather than repair. If the EF is greater than 40%, I tend to think I can probably fix that with a ring or some kind of repair. So that's the what. When do we do this? So what's the pathway? How do we get from all that diagnostic stuff? That first slide, that was one slide, was all about diagnosis. What about treatment? Well, if they're in the chronic group, they're post-MI and they're stable, this is long-term ischemia. If their EF's less than 30%, the first thing I want to know is it viable? So we get an MRI for viability. And if it turns out to be not viable, these are the perfect patients for a MitraClip because they have a high surgical risk. If the EF's greater than 30 or the MRI says it's viable myocardium, then we're putting them down the pathway to mitral valve replacement, repair, and coronary bypass. In the acute group, rather than the chronic group, who come in with elevated troponins, again, we have three groups: unstable with a balloon pump, stable with a balloon pump, or stable without a balloon pump. So the unstable people, if they were unstable with the balloon pump, they're going to go to emergency surgery. They're in cardiogenic shock. This is a salvage operation. Mortality is greater than 50%. It's a high-risk thing. Usually these are people with papillary muscle rupture who need to go to the OR. If they're stable, either with or without a balloon pump, then we put them into what we call the optimal timeline for coronary bypass surgery. In the United States, CABG. In Australia, CAGs, I guess. I don't get it. And the optimal timeline looks like this. Non-STEMI, first few days, depending on whether they got antiplatelet or not. For a STEMI, we like to wait 7 days because that lowers the risk of operative mortality for coronary bypass. If you have a ruptured papillary muscle, you can get them out. This is like a VSD. The longer you can get them out past 7 days, the better they're going to do long term. Then, of course, if they come in with Q waves, they have no chest pain, they're sitting there, and they got severe MR, and they've already completed their infarct, we're not rushing these people after surgery. So for the first three, we take them to surgery with that timeline. But the patients who come in with Q waves, we're putting them over here into this pathway of post-MI, stable, severe MR. Go through that whole pathway of viability. Now, you can have stable with a balloon pump in place, and the patient can go into congestive heart failure, have more pulmonary edema, and we need to intubate and diurese those people. That can also happen to people who are stable with no balloon pump in place, and we put a balloon pump in place to help with their pulmonary edema, and hopefully gets them back onto the optimal timeline. If it doesn't, and if they happen to have increased or worsening renal function, increasing pulmonary edema, or troponins, then we get them off and do the operation. So that's kind of how I think about what and when to do it, and that's kind of my algorithm of how I put these patients through. Now, why the next two papers going to show, we're going to talk about repair versus replacement. This is a mitral valve versus replacement. This is a randomized study from the Cardiothoracic Surgery Network. 251 patients, 22 centers, severe ischemic MR. It was randomized to repair or replace. Primary endpoint was left ventricular systolic ejection fraction, LVES index at 1 year, and then the composite and a secondary endpoint of residual MR at 1 year. And what these guys showed was that there was no difference in 30-day death, left ventricular end-systolic volume index, or 1 year mortality. No difference, and no difference in quality of life. What there was a difference in, and what raised everyone's eyebrows, was that there was residual moderate to severe or severe MR at 1 year, 33% in the repair group, and only 2.3% in the replacement group. So at that point, everybody in the States went, oh my gosh, if you come in with ischemic MR or acute MR with MI, you need to have a replacement. Now, this is the death curve over time. You can see they end up fairly close at 1 year, and this is the all composite cardiac endpoint, the same at 1 year. The contrary, and this is NYHA class. The contrary paper really comes from Scott Rankin's group, and this paper, I believe, was published in early 90s or late 80s, and it looked at 516 patients. I'm sorry, it was published in 2008. It's a retrospective study, and they compared mitral valve repair and replacement for ischemic MR. Note that there are different percentages of severe MR in their two groups. The replacement group had much more severe MR than the repair group. The bottom line is when they adjusted for ejection fraction and comorbidities, the survival for mitral valve repair was better long term, but it had mostly to do with a higher perioperative mortality in the mitral valve replacement group. And there was better long-term survival for mitral valve repair. When they just looked at operative survivors, there was less of a difference, but there was still some difference. So there's a signal there. If you talk to Scott and his group, they believe there's a signal that repair is still a viable option for ischemic mitral regurgitation. If you look at the Acker paper, which is a randomized study, they said, no, there's more residual MR, and that should be taken into consideration. So we looked at the very long-term mortality, the very long-term survival of patients with mitral valve replacement or repair. We excluded everybody and just got it down to 1,700, almost 1,800 mitral replacements or repairs for mitral regurgitation. And we can divide these patients into degenerative and functional. And we compare degenerative functional MR. This shows you what you already know, that if you come in with functional mitral regurgitation, you do much worse long term. This is relative survival, so it's adjusted for age and gender and operative year. So much worse survival. So if you look at these two operations, there's a much higher operative mortality for functional mitral regurgitation than there is for degenerative. But all these, for degenerative replacement or any functional, the operative mortality is the same. The only operative mortality that's less is degenerative MR repair. All other repairs and replacements have the same operative mortality. There's no significant difference for operative mortality in our 1,700 or our 400 functional patients of mortality. And when we look at long-term outcomes for FMR versus repair versus replacement, we find, most importantly, there's no difference. Second most importantly, it's important to know that the median survival of patients with functional mitral regurgitation is only 8.3 years. 8.3 years, median survival. And no difference in long-term survival, no difference in relative survival. When you look at the cumulative incidence function of redo, valve explant or redo for mitral valve repair, at 24 years, it's 5%. So there is a redo rate for mitral regurgitation. Remember, most people don't get to 24 years. There's 100% mortality by that time. They're all dead. So we only need to pick an operation that at most is going to last about 2 decades, and on average is only going to last less than 10 years. For mechanical mitral valve regurgitation, it's a 4% redo rate and 100% mortality at 20 years. For porcine mitral valve replacement, it's a 0% redo rate and a 94% mortality at 20-some years. For pericardial mitral valve replacement, the cumulative incidence is a 0% redo rate at 14 years, but only a mortality of only about 65%. So we put all this together. I'm going to skip. This is comparing all these other valves at 14 years. Mechanical at 14 years has a 68% survival and a 4% redo. Mitral valve repair has a 76% survival and a 3% redo, higher than pericardial MVR. And so when you look at all this, and I conclude, I had a whole bunch of other slides about summarizing all those data, but these are the summary. Expected survival is not restored for any mitral valve operation. We don't restore their survival to the age and gender matched expected survival. The median survival following FMR is only 8.3 years. And that represents almost a 60% reduction in expected survival over time. And 100% of the patients are dead by 24 years. So you don't need a 60-year operation. When you look at repair versus replacement for functional or ischemic MR, there's no difference in operative mortality. There's no difference in long-term survival. So to me, it comes down to the following. There's much more recurrent mitral regurgitation in every study you look at with repair than there is with replacement. In ACRA study, it was 33%. In our study, it was 5% with repair, but with replacement, it's 0. And so therefore, for me, if I see someone who's truly ischemic, that the durability of a pericardial valve mitral is way better than the durability even of a mitral repair, and the survival's the same. Thanks very much.
Thank you. That was an incredible summary and data you have, Anthony. I'm sure there'll be questions from the floor.
It was a huge topic.
Yeah, well, you covered it very well. Certainly, I think it was very extensive, looking at all the possibilities and how to manage these patients, and hopefully there's something you publish as well.
Thanks.
Aubrey.
Did you have a chance to look at the age of the patients, and was there any difference?
Yeah, so in our study, ours is that is age adjusted. So the adjusted survival, the observed versus expected survival, is adjusted against age, operative year, gender, and race, using US life tables.
Yep. So if you were faced with a 40-year-old, you'd still be happy?
So in a 40-year-old, so to me, again, it goes back to the second slide, which was, the algorithm of what you do. And again, so for me, if they come in with something that looks a little degenerative, I'm going to repair it almost every time. If they looks with something ischemic, like it's tethered, I'm really thinking hard about whether to replace or repair it. If it's a 40-year-old, I'd probably put a mechanical valve in. But I'd have a long discussion in my head about whether a mechanical valve would be better than trying to get a repair and then redoing that guy later. And if we redo them, do I want to do it against a tissue valve with a percutaneous mitral, or do I want to go back in and pull out a mechanical valve? So there's, again, a lot of discussions. The reason this is such a complex topic and go for so long, as you know, is there's multiple pathways down these algorithms that we can go. And you really, like your slide, Aubrey, you have to look at the patient, discuss it with the patient, discuss it with the patient's family, and I can tell you what I'm not going to do. I'm not going to put a mechanical valve in an 81-year-old lady like the picture you showed, and I'm probably not going to do a repair in her, right? Because I don't want to deal with a redo in a 95-year-old, even if it's a 1 out of 20 chance.
Thanks, Anthony.
Okay, thanks, guys.
Okay, our next talk is by my co-chair, Hiro Yamaguchi. He's going to tell us about emergency CABG for PCI complication, the very unfavorable situation to find yourself in. Thanks, Hiro.
Thank you very much, Trevor. Dr. Tavisak gave me the relatively tough talk, the emergency CABG after PCI complications. There's no COI disclosure. The PCIs nowadays became safe. The overall in-hospital mortality rate after PCI is 1.27%. But for the elective PCI, the in-hospital mortality was 0.65%. However, the STEMI is still around 5%. Those are the factors associated with the increased risk of the PCI-related deaths, advanced age, comorbidities like diabetes, chronic kidney disease, congestive heart failure, and multivessel coronary artery disease, high-risk lesions, normally having severe calcifications, And the setting of PCI, like STEMI, urgent or emergency procedure, cardiogenic shock, really affect on the mortality. There are some cases who have a procedural or peri-procedural myocardial infarctions caused by the acute artery closure, embolization, no reflow, side branch occlusion, and then acute stent thrombosis. The need for the emergency CABG has dramatically decreased in advances in PCI technology. In early 90s or late 80s, the need for the emergency CABG was around 10 to 20%, but nowadays, particularly after the coronary stent appeared to the clinical situations, the rate of the emergency CABG is very low and rare, is around 0.4%. But we have to carefully looking at why that patient require the emergency CABG, which is showing here. It's coronary dissection in a 27%, acute coronary closure, 16%, failure to close the lesions, 8%. Those three reasons were causing the myocardial ischemia. But the fourth reason, which is a perforation, is totally different mechanism requiring the emergency surgery. Of course, that's effect on the surgical risk. I will talk about in detail later on. The strongest predictor of the need for the emergency CABG is cardiogenic shock, acute MI, emergency PCI, multivessel disease, is a type C lesion, which is a long and diffuse, a complicated lesion. And overall, in hospital mortality for the emergency CABG is around 7.8% to 14%. To do the high-risk PCI, I think it is essential to have the heart team approach to make a decision for the revascularization. The guideline said it's class 1 indication to do the heart team approach for the patient who has unprotected left main or complex coronary artery disease. And also the class 2A indication is we need to calculate the risk of the surgery by the STS or syntax score, and then decide the patient to go to the surgery or the coronary interventions. So if patient had unprotected LMT, complex coronary artery disease or severely calcified disease, which is a high-risk group for the PCI, those patients has totally different risk for the PCI. It's not the 0.4% or something like that. That's why we need to have heart team discussions. Maybe Tawisak gonna agree with this. I want to share the one case we experienced 2 to 3 years ago. A patient was 79 years old lady. She was it's called us with cardiogenic shock due to the cardiac tamponade caused by the left main perforation during the elective PCI utilizing the low tabulator. She originally presented with intermittent claudication. That's why she didn't have any symptoms for the coronary artery stenosis. She was sent to us a few months ago, previous below knee popliteal artery patch repair, and then she improved the intermittent claudication. And then 2 to 3 months after the peripheral artery surgery, I will show the preoperative angiogram, which is having severe proximal LAD stenosis, and then which has calcification, and severe distal OM disease. We discussed at the heart team conference, and we all agreed to perform the PCI to the proximal LAD. The chest X-ray is clear before surgery, and then the ECG is normal without any ST changes, stayed in the sinus rhythm. We strongly recommend the cardiologist to do the preoperative CT angiogram for the high-risk PCI to look at not only the calcification onto the coronary artery, but look at the calcification or disease of the ascending aorta or systemic arteries, because that patient end up to require the balloon pump or require the emergency chest opening. That's why we normally ask the cardiologist to do the preoperative CT scan routinely. The coronary angiogram was shown here. You can see the severe calcification in the proximal LAD, and also have a severe stenosis in the distal OM disease. But basically, the proximal LAD is the concern, so she was considered to have one vessel disease. That's why heart team agreed to perform the PCI for that region. This is a preoperative cranial view. You can see the severe narrowing of the proximal LAD. Is anyone in this room who gonna recommend surgery for this coronary anatomy? Is there anyone here? You? Oh, Trevor. Very smart, I can tell you. Because this is a very high-risk case for the PCI. So she underwent the elective PCI for the proximal LAD, and they performed the rotablator. You know that rotablator, which has a diamond head drill to make the room for the stenting. Unfortunately, that was complicated with coronary perforation. She developed a severe cardiogenic shock, which emergently treated with pericardial drainage, and then the balloon pump was inserted, and then the PCPS VA bypass was started in the cath lab, and we were called to come to the cath lab. And then as soon as I saw that the situation, decided to do the emergency surgery. This is angiogram during the elective PCI. You can see the guide wires is crossing, and then you can see the diamond drill. The rotablator is treating the calcifications, which unfortunately made a perforation close to the left main stem, and she developed massive bleeding in the pericardium. So this is a drawing of the operating record. We performed the LMT perforation repair by transecting the ascending aorta immediate after we established the cardiopulmonary bypass. There was no time to take the graft before chest opening, so we immediately opened the chest, and then simultaneously asked the vein harvesting and patient on the bypass and the cross clamp it, and then the LMT perforation was repaired. I will show you the video from now, and then the two graft to the LAD and the OM with the vein graft. The chest was opened, and then the pericardium was was opened, as you can see, the fresh blood is blowing out from the pericardium. And we have to quickly open the pericardium. You can see the heart is like a big hematoma. It's not contracting almost at all. We urgently put the patient on the cardiopulmonary bypass. Even patient on the VA bypass, it's not enough to resuscitate the patient. The aortic cannulations and then the 2 venous cannulation to SVC and AVC. You can see the heart is just, shocking. So this is the first things to do, resuscitate the patient with the proper cardiopulmonary bypass machine. And then cross-clamp the ascending aorta. And then we transect the ascending aorta. Cardioplasia was performed by the direct cannulation to the coronary sinus, opening the right atrium. And we now looking at, this is a magnification view of the left main stem. It's a huge hematoma. We can't see what's going on here, and then we can see the left main stem here. Oh my God. Maybe we have to start. We don't have a mouse, right? Do you have a mouse? Next one there. This is a mouse. Yeah? Sorry. Better to not touch the button. Okay. Oh, it stopped. Let's go forward. In the usual bypass surgery, we first take the grafts, right? Mammary taking and vein taking. But in these situations, I think most important thing is to put the patient on bypass and start resuscitating. Yeah, again. So the left main stem was identified, but there is no way to look at the bleeding point. That's why I put the large protective mattress sutures to close the hematoma. And after that, I gave the antegrade cardioplasia to make sure there's no bleeding from the perforation point. And then the hemostatic stuff, the Takotsubo, to reinforce the bleeding. And then we are not sure whether the circumflex was interfered or not. So put the graft to the OM. And then another graft to the LAD. And then the transected aorta was repaired. And then the proximal of the LAD graft was put on the ascending aorta. And then the proximal of the OM graft was put on the vein foot. And hot shot was given retrogradely. The aortic clamp released. And then the heart back to the normal function. It was really good. So the risk of the emergency surgery for the PCI complication depend on the type of the PCI complications. Emergency CABG for the myocardial ischemia, which caused by the failed PCI from the coronary dissection, artery closure, failure to close the lesions. Those are the relatively easier to solve the problem if surgical decision was made in time. However, the emergency surgery for the cardiogenic shock, which typically caused by the coronary perforation, particularly the aggressive cardiologist treating the left main lesion, and then if the disaster happened close to the left main stem, which carries big disaster. And of course, for the surgeons, earlier decision-making to perform the emergency surgery and the earlier establishment of the cardiopulmonary bypass, those are the key, I think, for the saving the patient life. So in summary, the PCI is generally safe with overall in-hospital mortality is low, particularly low in the elective PCI. And the emergency CABG for the PCI complication is rare, with around 0.4%. However, the PCI for the certain the situation, like unprotected LMT, complex coronary artery disease, particularly, which has a severe calcification and require the low tabulator stuff, those are the very high risk for the PCI. That's why the heart team approach is mandatory, and then the wise surgeon has to recommend to do the surgery even in the one vessel disease. And then during the surgery, earlier decision for the emergency surgery and early establishment of the cardiopulmonary bypass to resuscitate the heart and the body, which is the key for the saving the patient. Thank you very much for your attention.
Thanks, Yara. Everyone's nightmare to get stuck with that one. Well done for salvaging the patient. Any questions from the floor? Aubrey.
Thanks, Hiro. A really interesting presentation, and congratulations on saving that patient's life. This question statement goes to the value of the heart team if, as surgeons, we don't understand what the risk of a non-surgical procedure is. So, for example, we can say, I can do coronary artery bypass in this patient with a 0.5% operative mortality, and the cardiologist can say, well, I can stent this. If we don't understand that that's actually a very, very high-risk PCI, in fact, that patient had extracoronary collaterals, which is why they got the perforation. In fact, so you should never do a rotablator in a patient where you can't centrally run the wire down, because it'll always perforate. You know, if we don't understand that, then it's very difficult to say this was a heart team decision, because in fact it really wasn't a heart team decision, because as a surgeon you didn't really have any input into that. Can you comment on that?
Yeah, I think it's a very important point. Surgeons has to know what cardiologists are doing during the PCI, but simple point is we can ask whether you're going to use a low tabulator to treat that region or not, which is one good questions the surgeon can ask, because we had a few complications during the PCI in my hospital, but all complication was caused by the rotablator use. It's normal, usual PCI will not cause the disasters normally, so it's relatively safe. But if they use the rotablator, particularly in the proximal region, we have to alarm the cardiologist and the hospital and to let them know there is a risk, high-risk PCIs. I think that's very important for the safety in that hospital network.
Do you think that any surgeon can be part of the heart team? I mean, you know, my point is that if you have surgeons who don't have a great deal of understanding of whatever it is they're contributing in the heart team. So if you're a surgeon and you're part of a mitral valve heart team and you don't understand what the limitations of a mitral clip is, or if you're a surgeon and part of a coronary heart team and you don't really understand what is a high-risk PCI or not, the value that you're adding to the heart team and the decision that that heart team comes to is always going to be worse than the decision that an educated surgeon can give. And we're seeing this in Australia, that you know, there are heart teams where the surgeon on the heart team acquiesces to the cardiologist every time because they don't actually know anything about the area that they're so-called part of the heart team. And I think this is a big problem. And while I agree 100% with the guidelines saying we should have a heart team, but it goes to what's the quality of that heart team. And we as surgeons have to take a great deal of responsibility in that. And you know, people who don't know what they're talking about
I understand
shouldn't be on a heart team. I don't mean that disrespectfully in this situation,
Sure.
but I just think it's a bigger problem, because all that does is it gives the cardiologists effectively a carte blanche, and they say, oh, well, the heart team decided, you know, so it's the surgeon's fault just as much as ours.
Of course, the coronary surgeons has to be involved in the coronary heart team, but I let the young people to go to the cath lab and at the beginning to learn the catheter procedure because the interventional treatment is expanding and going to be the important part for the junior surgeons to do that. So I think the education is quite important.
Yes, sir. Thanks.
Yeah. Just I have one question. Do you think the syntax score play a role to guiding us for this the perforation cases? I mean, which are the cases that is more vulnerable for the perforation? Higher syntax score cases are more vulnerable for the perforation. Do you follow this syntax score for your heart team?
I couldn't.
Could you speak into the microphone? Honestly, I couldn't hear you either. Sorry.
I mean, there is a guideline that patient with the higher syntax score should be going for the CABG, and the lower syntax score should be going for the PCI. The higher syntax score means more calcification. This should not go for the PCI. So sometimes this perforation, what we see normally, happens to this higher syntax score mostly, not for the lower syntax score cases.
Okay, I think the syntax score showing the complexity of the coronary anatomy, right? And of course, the higher syntax score patient come to the surgery with a strong recommendation. But even the low syntax score, just like I showed you this case, having the higher risk of the PCI and higher risk for the PCI. That's why even that case has to be discussed, not only analyzing by the SDS scores or the syntax score. I think that anatomy of the coronary artery is important, and our surgeons has to understand
So which are the sites for more perforation? I mean, you mean left main, proximal vessels? Which one you think the more vulnerable for the perforation?
You mean
Which site is more vulnerable for perforation?
Site.
Yeah.
Yeah, site is important. If the perforation occurred close to the ostium, it is a big disaster. If the perforation occurred to the distal OM or something like that, we can just put the hemostatic stuff like Takotsubo and to hold the bleeding without cardiopulmonary bypass, which is easier. But for this case, it's important and then impossible.
Thank you, sir.
Anthony?
Yeah, so this case would not even have fallen within those guidelines because the syntax of this was probably about 12. And but I think it goes to show the failure of the system and us as surgeons. It's our failure as surgeons not to be involved in discussing really almost every coronary case with a cardiologist. And the cardiologists basically do what they want to do without our input. In a high syntax score case, which this was, they would have gotten our input. Do we want to do triple vessel or should they bypass? But I will tell you that the best system in which I was ever involved with the best outcomes, we wrote about this in 1994 in Portland. We had a system, the Kaiser system, in which every single patient who's either going to have a PCI or have coronary bypass had to be reviewed by a group of surgeons and cardiologists. And hands down, they were the best short and long-term outcomes. And we have gone so far away with that, from that, and we have given this heart team lip service just to let the cardiologists do what they want to do, basically with a rubber stamp from us. So we have fallen down in that, I think. And that's more of I guess, a political statement than anything else.
Yep, totally agree. But if number is increased, it's going to be the very long discussion and meeting, which is the issue. But I totally agree, yeah, it's important.
Thanks very much.
Yeah, Trevor, I should do the way, having a computer by myself. I'd like to introduce Trevor Freya. Its title is Surgery for the Post-Infarct VSD, Time and Technique. Trevor, please start.
Thank you. In our efforts to be together at this conference, many of us have been given some extra talks, and this is one I've inherited from Dr. Moon. I don't know, but I think he probably knows more than I do about post-infarct VSDs. That's why he was given the topic, but overnight I think I've assembled something, and hopefully I can share that with you in a constructive fashion. I have no disclosures as a matter of interest. So the incidence of post-infarct VSD is actually decreasing. The surgical text will still tell you it's 1 to 2 to 3%, but really it's now down to 1.17.3. And that's really because of early thrombolysis. The state that I live in Queensland, even thrombolysis is so successful in managing acute myocardial infarctions that we hardly see LV aneurysms or this complication in this day and age, which in a way is a good thing because they're difficult to manage, but in a way a bad thing because numbers are down. And you'll see there's a statement that I make that should this actually warrant referral to high volume units that manage these patients because they can be quite difficult to manage successfully as we go through the whole discussion. So reperfusion is obviously very important because that will limit the degree of ventricular septal rupture by salvaging myocardium and preventing the expansion of the infarct. But the timing and presentation is closely related to underlying pathophysiology we'll go through a little later. So as all things in surgery, there's a classification which I found, never knew it existed, by Becker and von Mantgem. A Becker type 1 is a slit-like tear through normal myocardium. It usually occurs within 24 hours of an infarct. It's intramural hematoma which dissects through tissue planes. It's usually associated with a small infarct related to the PDA coronary territory. And the reason it's so complex to deal with, they think, is that shear stress is really generated by the hyperkinetic myocardium surrounding the infarct, causes this hematoma to dissect through different tissue planes. Becker type 2 subacute infarct due to erosion of the infarcted myocardium, usually the anterior territory, easier to deal with. And the type 3 is a long-standing complication of an aneurysm that perforates as a late phase post-myocardial infarction. Now, there are factors that are associated with post-myocardial infarct, VSDs, older age, female gender, tachycardia, low blood pressure, ST segment elevation, high cardiac markers, and high KILIP classification. And I'm sure all of you remember the KILIP classification, which I haven't heard that term for so many years. But for some reason, I do remember it. It's the degree of pulmonary edema or respiratory failure in patients with cardiogenic shock, for those that aren't aware of it. So the distribution usually is related to coronary artery systems, LED territory, which makes about 42% of patients. In general, these defects are easier to deal with, and the reason for that is that the level of the VSD is at the same side, on each side of the septum, same level. So it just makes the repair a lot more simple to do. The right coronary territory, which makes up more of these defects in 40% of patients, is a complex rupture. And there's serpiginous route throughout the inferior posterior septum. The tissue planes are dissected out by hematoma, and often there's free LV wall involvement, and therefore we often find ourselves operating more in this group of patients, and they're much more difficult to get through the procedure and salvage. Now, the clinical presentation really will vary, and a lot of factors will determine that, but importantly, as you obviously know, you're going to get an immediate left to right shunt. And in a patient that's not used to that, the heart will really struggle with IV volume overload and pressure overload. Now, that degree of shunt will really depend on the vascular resistances in both the pulmonary and systemic artery vascular beds. And so patients will either be very stable, irrespective of the fact they've got acute infarct and a VSD, or be in severe cardiogenic shock and clinically very unwell. Also to remember that if the RV function really goes down, often there's hepatic involvement, and these patients can therefore end up with coagulopathies and other issues relating to liver and renal impairment because of the high venous pressures. So really, the clinical presentation will be determined by the size of the index myocardial infarction, the degree of shunting that occurs, and the RV dysfunction associated with that. So how do we manage these patients? Well, we do know that surgery is a definitive form of therapy. However, they're not easy to deal with. A large is almost 3,000 patients who were reviewed in the STS database in 2012. So the 30-day mortality for these patients with surgery was almost 43%. So if you repair these patients within 7 days, the surgical mortality is 54%. But if you can delay them for after 7 days, as Anthony also spoke about the patients with severe MR, mortality drops to about 18%. So the bottom line is the longer you can get these patients down the track, the easier it is to deal with because you have better tissue to sew into and get a better outcome for patients. So the operative mortality in these patients is high for quite a few reasons. Obviously, these patients are often older, female gender, they're in shock, they have an inferior infarct, they preoperatively have balloon pump or are on dialysis, they have associated myocardial regurgitation, which makes them even more sick and difficult to deal with. Reduced setting, emergent surgery, and the timing of surgery, all those factors will have an influence on operative mortality of these patients with a ventricular septal rupture. Now, I didn't spend too much time on the surgical techniques because really, if you look at I spend quite a bit of time trying to get nice photographs of showing you what to do and what not to do, but there's so many different techniques out there which everybody thinks works better for them. So the bottom line is as long as you get the hole closed, better for the patient, but that's not always that easy. I think the most common ones we really adopt was that by Tyra and David, which is infarct exclusion patch technique for both anterior and inferior defects. Now, these diagrams always look really easy, but I know when I was involved in the inferior infarct, I had no idea how to close the damn thing, and I really struggled. So I don't think it's as simple as the diagrams make them look, to be honest with you. But we do have certain ways that we can look at managing these patients. So you can see in this is quite a busy diagram, but actually maps things out quite nicely. And if you operate these patients emergently within 24 hours, you have a 60% mortality. That's it. Patients don't do well. However, if you get a cardiologist to intervene, they do even worse. They're up to 88% mortality of patients. And that makes sense, because how do you land amplets in some mushy myocardium? And as you follow the diagram down, when you get past 7 days, patients start doing a lot better. And after 21 days, some patients might not require intervention, but in general, the longer they can get past the infarct and the rupture, the better they'll do with surgical outcome. And you'll see right on the top, there's another arm now, because we really have really good outcomes with ECMO, and patients can be supported that way to get them through the really unstable phase and get the organ function better, and then work out what's the best way to manage it. But we'll get to that a little later. A few years ago, the Quebec group looked at their management of defects, and they set up a little algorithm where they looked at the size of the infarct or the ventricular septal rupture by transthoracic echo, and depending on size, they would then decide how to manage these patients. They also were quite strict on trying to deal with residual VSDs by either leaving them if the patients were stable, or if they were still severe, then to have PCI. So the timing of surgery in these patients, as you can see, is actually quite difficult. It remains elusive. The American Cardiology Guidelines and AHA guidelines recommend emergent surgery regardless of hemodynamic status, and that was in 2013. I don't know if it's still the same. Stable patients with favorable anatomy, early surgery, there's no doubt about that. But delayed closure is probably what we'd advocate in patients with an inferior infarct. The only problem is that patients that are stable can suddenly deteriorate, and therefore still can make it a bit cloudy as to when to intervene with these patients. So this diagram or algorithm or flow diagram I actually found very helpful. You can either have a patient in cardiogenic shock or stable dynamics. If they're stable, they're surgical candidate, early surgery, or we delay them. If they're not a surgical candidate, the conservative management, or you do intervention by PCI and put an amplatzer in. The other hand, if they're in cardiogenic shock, if they're old and a lot of organ dysfunction, and their risk of surgery is prohibitive, even with intervention percutaneously, you palliate them. However, if you think that they probably patients that can survive the onslaught, you can put them on ECMO, the mechanical support, and then work out what you do with them from there. Look at their central function. If they don't recover, they go into palliative care only. And then if they can be bridged to surgical repair, they are. Or do they get a percutaneous intervention? And last but not least, don't rule out total artificial heart or orthopic heart transplantation for that group of patients. The big problem is cardiogenic shock. So the surgical mortality in these patients is 87%, but no better with percutaneous intervention. So most groups that see a lot of these feel that mechanical support for these patients really is going to revolutionize our strategies to dealing with a rupture, and we can make good decisions as a team to decide how to manage them. And there's even now been a level 2A with Class C evidence for abridged severe RM patients with mechanical support. And this is a rather busy slide, but it helps you to manage patients that have cardiogenic shock. It is hard for me to guide you through it, but basically you either have myocardial dysfunction only without real mechanical complications like a defect or mitral regurgitation or free wall rupture. Those patients obviously will have to be managed by either intensive care, balloon pump, and then surgical management, or plus minus mechanical support. The other group with just dysfunction, you'll revascularize these patients and then treat them and see how they recover. If they end up on ECMO, however, again, you'd have to assess them depending on the central nervous system recovery. If they don't recover, you just palliate them, and if they do, then go down the line of thinking whether you bridge them to surgery, destination therapy, or to transplant. But it's quite a useful diagram to sort of bear in mind as to treating the group of patients that are in cardiogenic shock. So in conclusion, ventricular septal rupture after myocardial infarction is a rare complication, but the prognosis remains guarded and grim. Management will include aggressive medical therapy, mechanical support, surgical repair, percutaneous intervention, or a novel surgical percutaneous hybrid procedure in these patients. Last but not least, unfortunately, some patients might just be palliated and decide on their own destiny. So the mechanical support really makes this quite a promising modality to help patients to become stable. You can either bridge them to delayed repair, transplantation, or just palliation. And again, a multidisciplinary, so the team approach to these patients is important, provided, of course, as we had discussed, that the input from people is constructive. We all know what we're talking about. And that's as much as I know about post-infarct VSD. Thank you very much.
Any questions from the floor?
I just thought I got away with it, Anthony.
Nah, well, you did. It's an easy one. I don't know. Let me ask you. So how long have you waited on a post-infarct VSD?
The ones I've dealt with,
Yeah.
I've had 2 late presentations. They were simple, and I was a hero because they did extremely well. The one acute case we did survive, but it was pretty messy with a residual shunt. So, yeah, I just don't see enough of them.
Yeah. You know, I've waited up to a month, and I've had a balloon pump in for 2 weeks. And so you can wait on these patients, and the septum firms up, and it's a much safer operation. And the cardiologists hate it if you have a balloon pump in for longer than 4 days because they think the patient's going to lose their leg, and it's not true. So that's one piece. The other piece that's really interesting, and I only learned in, let's say, the last 5 years, and I keep trying to learn even though I'm 61. I try to do new things. I learned from Toru Asai, who's here at this meeting, and I wish he was here. He had a double patch. He has a double patch technique from the right side.
Yeah, I saw that, yeah.
Yeah, and if any of you have seen it, he has it on YouTube. It actually works great. And it allows as much of the left ventricle to recover and stay as viable as possible. And it's a nice repair. It's hard to conceive of, but you know, the right ventricle is much more amenable to being cut open and then sewn back shut because the right ventricle would just be a passive conduit if it had to be. That was the other piece that I would just add, but nice job on short notice.
Thanks, a good input. Thanks, Anthony.
What sort of material for the patch you normally use? Just HemoShield grafts or?
I think I probably favor bovine pericardium, to be honest. That's what I would use.
I think the bovine pericardium is more flexible and then adjustable. That's why I thought it's better to put the bovine pericardium and then the HemoShield together with the glue. But that end up to having a very stiff material. And then the 2 weeks after surgery, the echo said residual shunt. And then patient got heart failure. And I redo the patient with the big decision. And then found that the patch was a little bit bulging. And that was causing the LV-RV shunt. That's why I thought the patch material is quite important. That's why I asked what's going to use it.
So what would you use now?
So the double patch with the bovine pericardium and the HemoShield patch with the glue. But that makes the patch too stiff and then makes the bulging. The one part that caused a disaster.
No, I don't see enough of it, so I'll be guided by you.
Okay, any questions? Okay, thank you, Trevor. We had a very good discussions with this session. Thank you very much for your cooperation.